Good afternoon, everybody, and thank you for joining us today for our special town hall to discuss our mission transformation. We have a little over 420 people joining us today across the country from our affiliate network, our Komen headquarters staff, as well as board members both at the affiliate level and our national board. We also have presenters coming to us today from our work from home locations in Dallas, Denver, Flagstaff, and Kansas City. So as you can see, we're also spread out across the nation as well. We will be going through a little bit of our mission transformation, but first some house cleaning. We are recording this presentation and we'll be posting it to my Komen following the presentation later this afternoon. Also, we will be taking questions as we do with every one of our town halls. Please use the Q&A section on your panel there at the bottom to enter in your questions, and we'll get to as many as we can. For those that we are not able to get to during our time allotted, we will try to follow up with personal answers as well. Today we're going to go over some just general look at our mission future, and then kind of do a snapshot into the future of the patient journey. So without any further ado, let me first introduce our President and CEO, Paula Schneider.
Of course, it's the most uncertain times, so I can understand that. But by now, most everyone knows that, at least at a high level, that we're about to begin on the next era in Susan G. Komen's history of impact. I want to personally thank all of our affiliates for your leadership across all fronts, particularly during this historic period of complete and total uncertainty. Your flexibility and your desire to put our patients first is pretty much central to who we are. And I want to thank the affiliate boards for your leadership and willingness to think big about Komen's future and how we can best help people across the country. So let me begin by addressing the operational changes we announced to consolidate into a single incorporation model over the next year. I know that many of you, this may come as a bit of a surprise. I want you to know that while we've talked about this and the pros and cons of moving in this direction over many, many years, this was not something we planned to do before our economy came to a grinding halt, thanks to the COVID pandemic. It was not in the plans in January or February when we began looking at budgets and mapping out our year, and we're doing this because of COVID-19, both for what it's done to our ability to fundraise and what it is doing to the very people that we're here to serve. So I can't really stress this enough, and I know you all know this, but we are facing an economic crisis unlike anything any of us have ever seen before. Nobody's lived through a pandemic. Charity Navigator has stated that about 80% of nonprofits only have about 3 months of operating expenses in the bank. And Komen is particularly hard hit because over 50% of our revenue is in large events, and no one knows when we're going to be able to safely convene people again. We're making the best decisions that we can make to make certain that we're here for the women and the men who need us, because it's an important mission that we have, and we have to keep mission first, which means that we have to contract so that we can survive, so that we can rebuild and we can thrive. We may have to use some of the money we normally would give to mission for operating expenses until we understand what the new normal is for revenue and right size for it. And we'll be fully transparent as we go. We have to come together to face this challenge. And we value and we need and we hope that the boards will come along and embrace the potential of what this can mean for us and the people in our communities who need us. It's not going to be easy. With scarce resources, we have to streamline our operations, and we have to narrow our mission focus on the things that are going to have the biggest impact. Things that we know that people living in a socially distanced world need, like our helpline and technology-driven solutions to interacting with people in the healthcare systems. And we know with millions of people suddenly becoming unemployed, our treatment assistance program is going to be more important than ever. We're going to continue to be in communities providing support to patients and opportunities for fundraisers and for volunteers, but how we help must change. Going forward, our organization is going to focus on 3 key mission drivers. Innovative breakthrough research. We will always continue with research. Research is the only thing that's going to cure cancer. Advocacy and direct patient support. And that doesn't mean that the other things we're doing or have historically done were wrong. And it doesn't mean that there will be only these things that we will do in the future. It just means that in this moment, we must focus on sustaining our organization for the future and doing the things that offer the biggest impact nationally for patients. Our patient-centered future is built on the foundation of a lot of really great innovative work that's being done by some of our affiliates. Yet in our current structure, we haven't been able to effectively replicate it. If we're truly going to make an impact, we need to be able to build on this innovative thinking and scale it across the country so everyone can benefit regardless of where they live. And we know that each community is different. We're very aware of that. But the major needs for people across our communities is often the same. And together we can focus on these key drivers and really make a difference. This is our opportunity to be truly revolutionary. Today, we want to start the conversation, and this will be the first of many conversations that we'll be having in the coming months, because it's impossible to cover everything in just one session. And I know that we have some really interesting presentations today, and I now want to bring on Victoria Velasco, the SVP of Mission, and Dana Brown, our Chief Strategy and Operations Officers, to take us through what the future could mean for us and the potential it has for being a major game changer in patient care and finding the cures for breast cancer.
Great, thank you very much, Paula, and thank you to everyone for coming together today for what Paula, which I agree with Paula, is the first of many conversations that we'll be having about the evolution of our mission. My name is Victoria Velasco. I'm the Senior Vice President for Mission at Susan G. Komen. And I know I've not been introduced to many of you, so I just want to take a moment to share that I've been with Susan G. Komen for the past 10 years, and prior to that spent 11 at the AACR, the American Association for Cancer Research. It was a real gift for me to come to Komen to be closer to the ultimate beneficiary of the work that we do as a breast cancer community, to be closer to the patients. So while my life's work has been in the conquest of cancer for more than 2 decades now, my personal passion has been for serving the breast cancer community recently here at Komen. And many of you know that that passion usually comes through when we meet to discuss the incredible progress being made in breast cancer today, much of it driven by the collective work that we have done together at Susan G. Komen. And while today is not a time for celebration, I want to underscore the importance of the foundational work we've done together since 1982 to not only open dialogue about breast cancer, but to push for early detection, to drive research progress forward that has made possible the life-saving treatments that we have today, and to advocate for the policies that have provided increased funding for research, that have provided patient protections and safety net services. We've been at the forefront of this progress for nearly 40 years now. So, sorry, Laurel, next slide, please. So a few years ago, next slide after that, and keep going, right there, thanks, Laurel. So a few years ago, our organization began to shift away from communications about our successes. And you know all those communications I'm talking about. We talked about the reduction in mortality rates, the early stage rates if you caught breast cancer early. We spent a lot of time celebrating our successes, and over the past few years, we've started to shift away from focusing on those problems that still remained for us to address as an organization. But despite improvements in survival rates and better access to care, we knew that some communities were being left behind and that research questions were being left unanswered. And this was the business case for breast cancer. This is why people still had to care about our disease in the communities that we served. So we know that African American women are dying from breast cancer on average 40% more often than their white counterparts. We don't know why some women who have followed every screening guideline and who have followed every single treatment plan for breast cancer are now living with cancer that has recurred, metastasized, and is now incurable. We also believed that a breast cancer diagnosis should neither result in emotional or financial ruin for anyone. Next slide. So this was the beginning of our bold goal. It was a rallying call to action to all of those who are working to end breast cancer, not just Susan G. Komen, for us to put our efforts where they were needed most to save lives. And for the past few years, our organization has been working diligently toward that bold goal, focusing our research efforts toward metastatic breast cancer and recurrence to find more effective treatments. And we've also been evolving to better serve patients. As Paula said, many in our affiliate network are at the forefront of this transformation, thinking of more innovative ways for us to directly serve and achieve our mission. We've been prioritizing health equity for the African American community, and we've also been making progress. But unfortunately, this is where I would normally talk about all the great successes that we've had, but unfortunately, the global health crisis that is COVID-19 and the resulting economic devastation that Paula has shared is putting not only the progress that we have made since announcing the bold goal, but the survival of our organization and also the lives of the very patients we serve at risk. I wanted to share with everybody some of the conversations we've been having in the field about the potential impact of this crisis, not only from the health of our public, but also the economic devastation that's happening and what this may mean for breast cancer. We convened our scientific advisory board just 2 weeks ago to talk about what they are seeing, because not only are they treating their breast cancer patients, they're also physicians who are on the front lines of helping those through COVID-19. Many of the hospitals that were serving cancer patients have now been transformed into ICUs, serving people on the front line of this crisis. And so they shared with us their observations in the field and how this might manifest for the future of breast cancer. And to start, we're very worried about the future of breast cancer research. We are hearing about hiring freezes across the country, and that impacts not only the regular workforce, but also the scientific community. We're concerned about the hundreds of young scientists who are graduating with degrees, ready to pursue the cure, only to know that there are no jobs for them for the next few years. Without science, how are we going to deliver that next life-saving cure for the patients that need them? We're also concerned about the impact on the delays in screening services. It's only been about 6 weeks to 2 months since we announced our recommendation to delay seeking screening services because of the risk that could pose to somebody's health. And we're already talking about what this may mean to the statistics, the late-stage diagnosis and the poor outcomes with just a short delay that we've had today. And we know this delay is going to continue. We're also concerned that many patients are having their treatment plans disrupted or delayed or changed. Some are being advised to delay care because of the impact of COVID-19. And many patients, especially our metastatic breast cancer patients, are concerned because their life depends on the next clinical trial. And we have heard that many clinical trials are closing to accrual, those that are existing today and those that we need tomorrow. For many, the massive job losses are resulting in the loss of health insurance, leaving many patients choosing between stretching their dollars for things like housing and food, or choosing to invest in their own health care. And with trillions of dollars from our government being invested in COVID relief, and rightly so, but we're expecting that some of the safety net services that would have been supported by those very same dollars will not be available, and we'll be leaving those critical programs that we have fought for through public policy unfunded and underfunded. These are very sobering messages and not my usual presentation, but I want to underscore the critical needs facing our breast cancer community today, and that are going to continue to grow in the future as this crisis unfolds. As a leader in this community, Komen is needed to mitigate all of these impacts. Everything I touched on are things that we have been leading for decades in places where we alone have made a difference. Frankly, there's no other organization that's available to serve as a leader on all of these fronts at this time. And I know many of you know how difficult it is to be that leader. You know, we've weathered criticisms and sometimes complaints. And I know at times that can be hard, and you can wonder, is there another organization who wants to come to the forefront and lead us forward? But that organization isn't coming. It is very difficult to unite the ability to serve patients, to drive research progress, to advocate for policy in every community across this country, and to be influential around the world. Komen alone has been that person, and we need Komen to be that organization going forward. As Paula said, 80% of the nonprofits may not be here to serve in the roles that we know them to serve in community. And many of these are the same organizations that we as Susan G. Komen have invested in to deliver life-saving care. And they may not be here to partner with us and to serve and to support. We must exist, and we have to continue to serve our community. We will get through this crisis. We will deliver on our mission, not only as we've strategized about how we evolve our ability to fundraise in these difficult times, we can also strategize and rethink the delivery of mission to serve people who need us today and to continue to serve the people who are going to need us in the future. But with fewer resources, we're going to need, as Paula says, to streamline and to laser focus our tactics, even though the 3 pillars of our strategy will not change. Next slide. So we are going to continue to invest in innovative and breakthrough research. Now, like other nonprofits, Komen has also delayed the awarding of some of our research grants, but we are continuing to increase our focus on leveraging technology and big data. At a future town hall, we're going to be sharing with the organization the establishment of Komen's first comprehensive patient registry and the first Komen-led patient-driven research study, which is designed to find the answers to the problem of late recurrence. And if we can find the answers to the problem of late recurrence, we are on the road to solving the problem for metastasis. This is hugely groundbreaking for us. It is the first time that an organization is putting a patient at the driver's seat for research discovery. We are going to leverage our standing and the trust that we've built in community to get this done and to eliminate the red tape that we know exists sometimes in the research enterprise. We're also going to continue to harness the power of our grassroots supporters to ensure wide-ranging patient rights and continued research investment through public policy and advocacy. We've been working on this for several years. It has never been more important. This COVID crisis has illustrated the critical importance that government investment has in public health. And we're going to have to fight hard to ensure that our breast cancer patients are protected while the government is addressing other issues in healthcare. You know that our national efforts are important, but it is critically important, and you've heard me say this before at town halls, our battlegrounds are going to be in the states. And we are going to need local knowledge, and we're going to need volunteer presence in order to raise our voices and ensure that our key initiatives are heard. But most importantly, and I know that's why we're all here today, what does this mean for our patients in our communities? We need to provide that direct patient support. With many of our partners unable to sustain through this crisis, we have to stand ready to step in and serve. And we were already on the road toward these direct services. Many of our affiliate colleagues have been working with us for the past few years to evolve in order to be able to deliver life-saving care right to the people who need them. But the pandemic has made it clear. We need to hit the accelerator and transform the patient engagement and care experience and break down those remaining barriers to care. So what does that mean in real time for the immediate future? So this is just a start of some of the things that are key programs for us that we can continue to deliver on today while we are building together for the future. And I'll talk about that in the next slide after. We've discussed that we need to stop doing things. Our constrained resource environment is not going to allow us to do everything that we know must be done. So difficult decisions are going to be made. And for the immediate future, that very likely will mean ceasing community grant-making operations and potentially other programs that have been integral to Komen's work. As Paula said, this does not mean this work has been unimportant. This has been foundational to us transforming breast cancer over the past nearly 4 decades. And this also means that this work will never be done. It doesn't mean this work will never be done again. We need to take the time to pause and to consider our future and to allow Komen the financial runway to be sustainable in order to serve for the future. We need to continue to serve, but we need to continue to serve in a more strategic and tactical way. There will be conversations with each of our affiliate colleagues about these decisions and about the strategy that I'll talk about on the next slide. But I want to share with you how we're going to operate and also continue how we're going to expand and make our existing key programs more robust. So first, let's talk about our breast care helpline, which provides compassionate support, information, and resources to callers nationwide, which is right now based in New York. I know that many of our affiliate colleagues provide similar resource navigation services, and one that comes to mind is Jill Fricker right here in Colorado at the Colorado affiliate. How can we incorporate some of the thinking and the planning that Jill and other colleagues like her across the network have incorporated into their services to make our national helpline more informative and more responsive to the needs of every community? How can we learn those best practices and ensure that that same experience and that same high quality is delivered to every caller in every state? We've also been supporting our National Treatment Assistance Program that provides financial relief to ease the burden of care to patients no matter where they live. And many of our affiliates have already joined the national program to provide collective investment for this service. But some of our affiliates like San Diego are taking a different approach and providing direct payment for things like screening and diagnostic services. Can we incorporate the learnings from that program to expand our treatment assistance services and also allow that same high quality experience to be delivered to patients in other states? I also think we have an opportunity to consider the guidelines for the current assistance program. Many of our colleagues have shared their interest in providing not only an increased financial level of support to patients, but discussing how we can actually help more patients overall. More patients are going to need us. We'll continue to work together to ensure that our Metastatic Breast Cancer Impact Series events are presented both through virtual means and, when resources and public health guidelines allow, to allow those to be delivered in person. We seek to expand our current programs that give patients information about clinical trials, but also to explore together how can Komen work in communities to help accelerate accrual to life-saving studies. We know that of the percentage of breast cancer patients that could benefit from a clinical trial, only about 3% of patients actually are served through a clinical trial. And the percentage of patients who are from communities of color is far less. Komen can play an integral role of changing those statistics. We also believe that part of our future work in communities will be through patient navigation. But first, we need to consider the workforce needs and the policy implications of patient navigation for Komen. This is work started by Linda Tintali and the Greater New York affiliate, and this could be scaled nationally to create a national approach for Susan G. Komen and patient navigation. And some of our colleagues, like the coalition that's been built in California, are already starting to serve patients directly, navigating them through the continuum of care. Again, can this approach be replicated in other communities? And we do need a national framework in order to guide implementation and also to measure our success. This is key because we're also exploring a partnership with Walmart in collaboration with Katie Stone and our colleagues in Atlanta to bring patient navigation to hard-hit rural areas. And this approach can also be replicated in other communities. Finally, we'll continue to work through our African American Health Equity Initiative, which is made possible through the support of the Fund 2 Foundation to improve outcomes, starting in our 11 priority cities. But we won't stop there. Next slide. We need to have a conversation with all of our affiliate colleagues about the collective vision for the delivery of mission. We'd like to establish a mission advisory committee with invitations and an initial survey being released in just a few weeks, with working groups formed to address specific issues in mission delivery and working group meetings starting in June. Our goal is together to decide the best path forward. I know that the affiliates are doing a variety of programs, more than what I showed on the prior slide, and together we need to assess those to determine what is the best way for us to improve the health of our communities, but also to consider how we together can overcome the barriers created that our sometimes narrow definition of communities can create. And I want to say that again. In our current model, the experience of community is widely divergent. We cannot say that all communities experience the same services from Komen or the same quality of service, or frankly, any services at all, where we do not have a service area. And if we truly strive toward achieving health equity, that really does mean serving all. So we need to think about democratizing the Komen experience for all, so that all people, no matter where they live, see in Komen writ large their community. Next slide. So let's talk about that. I know we have built the legacy of our organization on providing a sense of community. But I want us to take a minute to consider the new vision for what community may mean. We often talk about community in terms of borders, our service area, our zip code, our neighborhoods. And people do find community where they live. But people also find community reflected in who they are and what they believe in. And at Komen, we build community among those like them. Think about the bonds that are formed by our African American community when they come together, or the shared experience of our metastatic breast cancer patients, or even the peer relationships that we've built amongst the scientific community we've supported. People also find community through shared experiences and goals. The community that exists within the 3-day bubble, or the community found among the hundreds of people who join us at our advocacy summit. I want people everywhere, regardless of how they may individually find community, to see in Susan G. Komen their community. At every place they see themselves reflected in us. It all starts with us building those relationships in a new way with individuals in our collective community for them to find a place with us writ large. But it all starts with building that trust with the individual. My colleague Dana Brown and I have been working with our teams on an approach using technology to create those individual relationships with Komen that we've never done before. And this was envisioned to ignite all the things that we've just discussed. How do we drive research progress? How do we serve patients no matter where they live? How do we activate individuals around our mission in a robust way? How do we marry all of these things together? And we've talked about creating this platform to connect with patients, provide those resources, overcome those barriers, invite patients to be part of the world's first patient-driven research program, and invite patients to not only lend their data to the cause, but to lend their voices to the common good. This approach can provide us the backbone and the foundation, but it's not the only thing, it's just one thing. And as we said, there'll be many more conversations. But it all starts with the patient, the ultimate beneficiary of our work and the reason that we're all here. The patient must come first. So I'd like to turn the presentation over to Dana so she can share with you a snapshot of what this backbone could be.
Thanks, Victoria. So just again, I want to take you back to a couple of touchstones just from a couple of moments ago, right? Our bold goal is to reduce the current number of breast cancer deaths by 50% in the US. And how do we do that? By finding breakthroughs for the cures for the most deadliest form of cancers and ensuring that all people get the care they need. So in order to achieve our bold goal, we all have to recognize it starts with the patient, right? A patient who needs help, a patient with whom we win their trust so they can share their health data to lead us to basically being able to fuel the research, right, in order to find the cures to save lives. As Victoria mentioned, we want to leverage the power of this patient-shared data to accelerate innovation in breast cancer care and treatment for those on their journey today, improve their outcomes to find the cures, save lives, and enter a world without breast cancer in our future. This requires establishing trust with patients, it requires scale, and it requires diversity. So as you think about those different definitions of community and what community means to each of us and to our patients, we need to be able to think about how through scale and diversity, we can reach all people. So let's go ahead and go forward to the next slide. So I'm gonna spend a few minutes here and I'm gonna tell you the story of Peggy. Peggy represents, all women and men anywhere who want to take charge of their breast health. And Peggy in particular is going to go on her breast cancer journey with Komen. So, in the 90-some minutes, right? So some of you may be, still wondering a bit of, the urgency around these changes. Why now? But I just want to also remind us as we stand here, right, or sit here and look at Peggy and go on her journey with her. In the 90 minutes it's taking us to share this story, this vision with you, 7 people will lose their life to breast cancer. So if there's never a more urgent time, right, or a call to action, I'm not sure what exists. So Peggy is a 44-year-old mother of 2 in a small town, USA. It's population 25,000. It may look very similar to small towns where each of us grew up. It has crosstown rival high schools, your typical slate of fast food quick service restaurants like McDonald's and Applebee's. It has a Home Depot, and it has a Walmart Supercenter that really serves as the hub, right, for community interactions and all your daily needs for shopping. Peggy works as an office assistant in a local law firm, and her husband is on the local police force. So let's go ahead and go forward to the next slide. So this is the journey we're going to go on with Peggy. I'll be honest, we're going to do a bit of time travel. Peggy's journey may not look like journeys of other patients that you know. And what we're hoping to build right through this platform and through our mission services is a journey that can be personalized. So I just ask, use your imagination as we go through Peggy's journey. And in particular, look for all the ways in which we manifest community, right? And we have touch points with Peggy. Touch points that are up close and personal, touch points that can scale, right? So all communities everywhere. And touch points that reflect the diversity, right, of the populations we need to serve. So let's go ahead and go forward to the next slide. So Peggy, one Saturday afternoon, while she was doing her typical grocery shopping for the family for the week at a local Walmart, saw on the community bulletin board during checkout that there was going to be a mammo van present the following weekend, and it was offering low-cost mammography services. Being in her early 40s, Peggy was vaguely aware, right, of the need, but she went ahead and picked a flyer up, right, off of the bulletin board and took it home. And later that day decided, essentially, why not? She goes to Walmart multiple times throughout the week. It's convenient, easy access. I'm going to go ahead and sign up for my first mammogram appointment. This is a photo here, a snapshot, right, of the environment in that local community where Peggy went to her Walmart to receive her first mammogram. And there's a very important figure in this photo, the African-American woman named Joy, who later is going to become Peggy's patient navigator. So via this mobile mammography service, and it's not just mammography, but it also is a leap forward in the future in mobile diagnostic services as well. Peggy has her mammogram, needs to have some further diagnostic services, and learns she has breast cancer. The mobile technician gives her a hard copy of her results and encourages Peggy to immediately follow up with her local general practitioner. Also gives her a pamphlet with some additional information about breast cancer, about oncologists with whom this local community center partners in a nearby larger town about an hour's drive away. So go ahead and go to the next slide. As we can all probably relate and have heard the words of other breast cancer patients before Peggy, she goes home with her mind just full of worry and concern. It's just been turned upside down, not really sure what to do next. So later that evening, after kids are bathed and put away, tucked into bed, she breaks out the laptop and does what any of us would do, right, in Google's, I need help with breast cancer. Luckily, Komen's helpline is at the top of her search results. It looks so easy, right? She could just call directly, right, from her cell phone and get connected to someone who cares and can answer some of her questions. So she goes ahead and calls the 1-877 number and connects to the Komen helpline. Let's go ahead and go forward to the next slide. So she calls the helpline, desperate to talk to somebody who understands this new world that she's just entered. The Komen helpline specialist, right, featured on the left, she's calm, reassuring, takes Peggy through a battery of questions, kind of intake questions, to find out her basic status, when and where she received her mammogram, what information about the results were communicated to her that she can remember. And she goes ahead and sets up a Komen patient account for Peggy in the Komen Health Cloud. The helpline specialist does 3 things with Peggy still on the line. Number 1, she's going to walk Peggy through how to access her health account at all times, right? And opens up a personalized online resource folder So information about breast cancer, treatment options, etc., are always at Peggy's fingertips, and she knows where they are. Number two, she tells Peggy that they're always available. So 24/7, she can access more information through the website. She can use a click to chat feature, right? For those of you who maybe have used that when you're looking for help or support from a particular brand or product or service, as well as she can always call back, right? The 1-877 number and talk to someone on the helpline. Lastly, she tells Peggy about a follow-on service, particularly because Peggy has received a diagnosis of breast cancer, about patient navigation, and explains that a patient navigator can be there by Peggy's side through every step of her journey, helping her to make sense of questions and information that's going to be new. And she asked Peggy, would you like to be connected to a patient navigator and learn more about the help they can provide? Well, Peggy enthusiastically agrees. Anyone that she can lean on right now, because Peggy has to be strong for her family, right? Her children, her husband in the evening is a welcome relief. So the helpline specialist immediately transfers the call to Joy, the patient navigator that we just saw a couple slides ago. Joy asked Peggy a few more questions, just getting a sense, right, of her state of mind, other things about her current status, what you and I might know as social determinants of health. And these are very important questions because they're going to be able to set a pattern or a baseline to be able to monitor Peggy's health and wellness throughout her treatment journey. Early indicators where Peggy might need treatment assistance or where she may need more psychosocial support. So she captures all this information, the navigator Joy does, in Peggy's account, even things like what's Peggy's access to transportation, does she have options for childcare, what are her work hours? She wants to make sure that she's able to connect Peggy with the best care professionals that's going to meet Peggy's personalized journey and needs. She offers to call Peggy back in just a couple of days as Peggy's looked through basically the pros and cons of different oncologists that could be available to help her on her journey. So next slide, please. So as the navigator and the helpline specialist had helped Peggy understand, Peggy can always get back into the Komen Health Cloud and look at her dashboard, where at a glance, she's going to be able to track over time, progress, and information included in her medical health records, who her care team is, on speed dial, right? Speed email, speed click to chat can be her patient navigator. Prominent, right, reversed out in pink, is a 1-877 number to always call and be able to talk to a human, right, on the other end of the line that understands your situation and can offer support. And we also begin teeing up more information about how Komen will be there for Peggy throughout her treatment journey. Information about clinical trials and Komen-led research progress. So let's go ahead and go forward to the next slide. We also, through the Komen Health Cloud, can proactively engage Peggy. So it doesn't just have to be Peggy taking the initiative, right, and coming and checking in status on her Komen Health account, but we can set up personalized journeys through email communications, phone calls, etc., to keep Peggy connected. And this is just an example of a welcome email welcoming Peggy to the Komen community and reassuring her that we're going to be there with her every step of the way, and helping to remind her, because her mind is going to be so full of all the new information and decisions she must make, in concert with continuing to hold down her job and care for her family, Komen will always be by her side. So let's go forward to the next slide. So behind the scenes, like all of us today, working from home, right, through being virtually connected, the navigator Joy is checking her patients, right, that are in her area of responsibility. So she can see at a glance, as a patient navigator, who are the patients I'm responsible for, who are my referral partners in case I need to immediately contact them or follow up if I were waiting for test results or other information to be shared about my patients. What are my next tasks? You can see here, top on her list is a follow-up with Peggy about her SHERO research study project. Appointments that are upcoming with Peggy, so the navigator can join via telemedicine or virtual, just like we are here today in our webinar. And what are other resources that the navigator has at her or his fingertips to help their patients on their journey? So let's go ahead and go forward to the next slide. So we're going to fast forward a bit in time. Peggy's at her oncologist appointment, and through the advances made in telemedicine and telehealth, Joy, the navigator, can join her virtually. So literally just a click away on her smartphone or through her oncologist doctor's office, we can have Joy join the conversation and be there and ask questions. So during the appointment, the doctor, walks Peggy through various treatment options. Her mind's a bit of a blur. Just as she thinks she understands one option, another one is presented and kind of the pros and cons. Joy chimes in often throughout the conversation, reassuring Peggy she's taking notes and that they can connect after the appointment and go back through the options and answer any additional questions that she may have. The navigator, Joy, also reminds Peggy that when she's checking out at the doctor's office today, remember to consent to have her medical information shared with her Komen account. So it's really important, right, that we can ingest, right, her medical records and use the data contained within to proactively be able to predict and recommend next best courses of action, follow-ups, match her to clinical trials, or opt her into research projects. So let's go ahead and go forward. So later that evening, because of the value Komen has provided so far, being there with Peggy every step of the way, whether in person or virtually connected, Peggy decides, well, I'm going to go back online, right, into my Komen Health Cloud and just explore a little bit more about some of the information I learned at the doctor's appointment today. She engages with a live chat feature that's utilizing some really advanced technology like artificial intelligence and machine learning that can take her through a natural language set of questions and be able to guide Peggy to find her own resources through the Komen supplied information database. One of the tools that Peggy decides to engage in is determining, is she a match for a clinical trial? So she answers some questions that are presented to her in really easy to understand language to help pre-qualify her for being a clinical trial match. The answers are returned right away, right, through the benefit of technology, and she learns that she's a match, and she's presented with two options. Does she want to learn more, or is she ready to dive in and apply? Peggy's not sure. She really wants to chat with her patient navigator. She really wants to talk to Joy and learn more about what this is about. So she just checks the option to learn more. So later, during a follow-up conversation with her navigator, Joy, she talks about her experience with the clinical trial matching tool and asks to learn more about what it means. So let's go ahead and go forward to the next slide. So meanwhile, back at home, Peggy's husband is getting a bit worried, right? The time it's taking for Peggy to take off work, she's about to run out of any vacation time that she had. It's a long drive to and from her doctor's appointments. The costs of her treatments are expensive and piling up. She's heard Peggy mention that in her conversations with the Komen Helpline and with her patient navigator, Joy, that there are options for treatment assistance. There are financial options available. So when Peggy goes to work the next day, her husband asks if she's okay if he calls the helpline and just learns more. And she says, of course. So he calls the helpline, and after a few quick questions, the helpline quickly matches the husband with Peggy's account and sees that she's already been pre-qualified for treatment assistance based upon prior answers to questions throughout touch points with her navigator. So he offers to answer a few more additional questions about their financial situation and learns that they are qualified for treatment assistance options. Now with Peggy and her husband, they are a part of the 30% of Americans that are underbanked or unbanked, meaning they don't have access to traditional checking accounts, check deposit services, etc. So one of the options that they have is for the ability for their treatment vouchers to be transferred to their local Walmart Money Center and go in and redeem those options. So this is a snapshot. Again, we talked about some time travel, right, in telling the story of Peggy, of those treatment assistance vouchers being able to be redeemed at their local Walmart. So go ahead and go forward to the next slide. We're almost to the end here, right, of Peggy's treatment journey. And just bringing this back full circle, remember, for the bold goal, provide access to the care they need for everyone, right, in order, right, to be able to have research happen to find the cures. So because of the trust and confidence Peggy has built up through her treatment journey with Komen, she gladly wants to share her information for others to be able to find the cure, right? Pay it forward to others who might also be on a treatment journey. So if you look, right, and I understand if you're looking on a small laptop like I am, it may be a little bit hard to read, but the center snapshot says a Komen research study, right? So Peggy, again, has went through a battery of intake questions and matching to understand that she is a match to participate in this patient-directed, Komen-led research study. So let's go ahead and go forward to the next slide. So this is a diagram, right, really, of that journey we just went on with Peggy of the Komen Health Cloud. And there are 4 major sections or elements, right, in our health cloud and in our patient journey, represented kind of color-coded here. Starting with the pink, right, and this is where Komen has started with community engagement, ending in the blue, right, with sharing information for research to find the cures. Over the course of the next several weeks and months, leveraging the work of the Mission Advisory Committee that Victoria just mentioned, our current patient advocates, we want to work together to round out these solutions to be there at all of these critical touch points in a patient journey. From having folks opt in, and it's important that they opt in even if they're in a healthy state and just want to be kept aware of their breast health, as it is for folks like Peggy that have to go on a breast cancer journey. How we serve them throughout their time through that journey, how we continue to engage them and their care team in the ecosystem, right, of full continuum of care, all the way through leading to clinical trial matching and research in order to find the cures. So our goal, our hope is that the Komen Health Cloud becomes the premier patient, care team, and researcher relationship platform that harnesses the power and security of the cloud using social mobile technologies as well as low tech, right, and low touch, so that we can provide access to it for all people everywhere. Provides a complete view, right, of the patient, intelligent care collaboration, and a connected patient experience. So patients, helpline specialists, patient navigators, care team members, or researchers can access both clinical and non-clinical patient data. So let's go ahead and go forward to the next slide. So at this point, I'm gonna, hand it back over to Victoria, but I just wanted to end on one note, right? That Peggy's now and forever will be, so this is year-round and lifelong, a member of this larger community of the Komen family, working towards better treatments today and the cures for tomorrow. So with that, Victoria, I'm gonna turn it back over to you.
Okay, great, thanks. Thanks so much, Dana. What we just saw was an ideal state of what could be a care relationship, a caring relationship with a patient. A lot of what we do now in our service through Komen is I feel that sometimes we gather a lot of really good data on our donor relationship with our individuals in our community. We're gathering a lot of data through Salesforce, and we're building relationships based on that. But we don't yet have a good framework to create a caring or clinical relationship with the people that we serve. In the research team, we've been working with some of our cancer center providers to understand what does that care journey look like. And for those of you who are living with cancer now will understand. The study that we worked with at Vanderbilt University found that on average, a cancer patient sees upwards of 14 different providers, and none of those records are really connected. It's a huge burden on the patient and on the care system to understand the full picture of the journey someone had been through during their breast cancer treatment. In some ways, we are similarly replicating the same experience at Susan G. Komen because our records of how we care for people are disjointed. We really have no way of knowing when an individual has called our helpline. Have they already reached out to an affiliate? Have they been served by one of your partners or grantees? Are they also receiving a treatment assistance program? Both of those things are firewalled right now. Do we know if they signed up for a clinical trial that they read about? And do we know what's happened to them on their journey? Do we know if they need further support? It's really difficult for us to provide that comprehensive experience of support when we really lack the platform and the data to do that. but also to help anticipate some needs and to build that one-on-one relationship. And this platform is one way that we can start to build that relationship and build that trust and be able to serve in ways that we've never served before. It's a platform, but it's not the only answer. As you went through and saw what Dana was showing you, it's just, this is the technology piece that could drive the back end. So I'll talk about that first. Part of this gives us the power as an organization to collect data and better serve. How can we create an experience and learn about a person so we can either anticipate their needs or change something if it didn't work, and really build a picture of the people that we're helping. From the patient's perspective, and Dana touched on this a little bit, right? Part of what we showed you on the front is a spaceship, but some of our communities need a sedan. So we need to, again, democratize the experience. The back end provides us a lot of power. Dana started by sharing that the relationship began with a phone call, and it was the helpline operator that was taking in all the data. The person was just having a conversation. So we want to be able to honor those differences in a person's personal preferences, whether they'd like to be more technology driven and use the app, and that might grow as time goes on and people become more technology comfortable. But we're also going to honor ways that people would like to interact or communicate in their care journey, whether it is in English or the Spanish language or something else, or whether they would like high tech and low touch or the other way. But what's important for us for the future is to gather this data to help inform how we are going to serve. It also provides us really robust data to inform our public policy efforts. Imagine if we're going to advocate in the state capital of Wyoming, and we have incredible data that shows the number of patients who have sought assistance from us because transportation is an issue. Is that something we can solve by policy? Is that something we can solve by a state program that benefits all patients in that state and not just the few that call the helpline? So it will help us build that relationship. It will help us curate and develop better programs, but it also democratizes the provision of care where people need. A lot of this is aspirational. I saw a question, is this operational right now? Not yet, but a lot of the underpinnings that you see, the provision of helpline services, treatment assistance, we're starting patient navigation. We know resources. The research platform is in development. These pieces are all coming together to help support our future. I think this is a way for us to layer on other programs. As you saw from the presentation, it's not just about technology or the services that I mentioned, but it's also about providing engagement and education. We are still going to need to provide content to people where they live in the way that they need it. So a lot of the programs that we've been working on will continue, will just be supported in an incredibly robust way that we've not done, and that will help us for the future. So I'll stop there because I know there are at least 14 questions that have come up so far. Before I end and go to Q&A, Paula, I just wanted to see, do you want to comment now or wait to the end after we get through some questions?
I'd like questions first.
Okay, sounds great.
And this is fluid, right? Understand that we're working on these things as we go. And the world has changed so dramatically in the last 60 days that, you know, we have to stay fluid and we have to bob and weave. But these are things, obviously, we didn't just start these processes of our home and health cloud in the last 60 days. These were ongoing, but we did secure funding, or we believe we have secured funding from Walmart for the app and for the state of Georgia. And they do have plans to roll out in other states. And they have a very aggressive plan to roll out in other states. So we think that there'll be a big opportunity for us through our partnership with Walmart. But if it's not with our partnership with Walmart, we'll figure out other ways because we are still going to get closer to the patients.
All righty, we have several questions that have come in. So let's go ahead and get to it. First big question is about the Treatment Assistance Fund and wanting to know what types of things will it be covering? Will there be payments for things like diagnostics and screening as well?
Mm-hmm. Great question. So the current treatment assistance program is more to cover supportive services to keep people in the continuum of care after they've already been diagnosed. So things like transportation, childcare. We've recently expanded the definition in response to what's happening in our world to include food and other services like that. I think we have an opportunity to expand services to provide, like our colleagues in San Diego have done, provide direct payment for diagnostics and other forms of relief that patients need. I think that's all up for conversation. We do know that the impact of the financial toxicities of cancer are going to go far beyond the communities that we've typically served. Right now, our program is geared toward families that are at 250% of the federal poverty level. But as we know from what's happening across the country, many more people, including the working middle class, are going to need us. So we do have an opportunity to expand what is classified under treatment assistance.
Question about the local resources information. How will that be gathered as it relates to the helpline?
Mm-hmm. So our helpline staff, even though they're based in New York, cover the entire country. So they already have a robust process for gathering local data through just in time. What all of you who work in community know this, that the landscape changes on almost a constant basis. So the helpline team work to ensure that their information is timely and is current based on the searches that they're doing for callers right now. We do have an opportunity to be better at covering the entire country and to do more services. This is where we can lean into the expertise of our affiliate colleagues to see what's working there, who do we need to know, and how do we build our compendium of knowledge to understand what's being needed in each community. That may mean that we're going to place workers, helpline staff workers and social workers outside of New York City. And I think that's something that we should consider.
There's a question about our resources. Will we continue to translate them, and how will that relate to the cloud and the helpline?
Absolutely. We certainly have to translate and make services available in Spanish, which is becoming the most widely spoken language in our country today. Our current services and translation of materials cover a variety of languages, so we need to consider that. I know many of us who have worked in partners have worked through translation services to ensure that people get the care they need, and that is something we will consider going forward as we establish patient navigation.
There was a question about mobile mammography. One of the slides showed that, and there was a mention of Walmart. Is that something that we're going to be doing with Walmart, or is that a key thing that will be rolled out across the country?
We hope so. Walmart, can you hear me? Yes, I think working with big organizations like Walmart provide us unprecedented reach. And I think reaching in communities where we don't have a continual presence. So looking at, as Paula said, at Walmart and other partners that can help us break down some of the existing barriers to care. Walmart would be a hugely impactful relationship. There are millions of women who walk through the Walmart doors every single day to shop for themselves and their families. So it gives us an opportunity to really disrupt the healthcare landscape. Sean, I'm going to cheat a little bit. And I looked ahead at one of the questions and saw that there was a concern about ensuring that with Walmart or any partner that we design these programs with the continuum of care in mind. We all know from the decades we've been working in this field that it's not one and done, screening and you're gone. We need to ensure with every partner that works with this organization that we're keeping in mind that the journey to healthcare doesn't begin and end with screening. So that is part of the conversations that we're having, that we need to take care of people at all steps of the process, whether it's directly from Komen or in partnership with others. As we said, that approach may change, but we know that we cannot do this alone.
Okay. This is more of a technology question. Will the Komen Cloud data sync with Salesforce?
Oh, that's a really great question. And I know, Dana, we have to talk about this. I'm just going to shoot from the hip. Probably not, but maybe. So we're really concerned. We're really concerned about HIPAA, right? So the privacy of medical records to ensure that people who are working with an individual from the donor side of the house don't see information about their health status. So we do understand that privacy and protection of our patients is paramount. And we're working with Dana, her IT colleagues, and our advisors to ensure that happens. Dana Brown, did I get it right?
Kind of. So yeah, I'll say the fact that Peggy is one and the same person would be known from, I'll say, a donor services point of view as well as from a patient services point of view. But to Victoria's point, information about her health status, any of her HIPAA protected information would not be able to be viewed unless it was by a staff member that has that, kind of HIPAA level certification, right, on a need to know basis. But you want to be able to address, a situation we do not want to have happen is, someone call a patient who may be in active treatment and, come across as maybe being insensitive or not aware, because it could undermine the trust they have in their patient relationship with Komen. So they're both solutions are meant to be built on top of a Salesforce platform. And so they are in sync, but information will be protected on a need to know basis.
A follow-up or related to technology. A lot of this has been discussed about technology. What are we doing for those who do not have access to the internet or technology to be able to access these things?
Mm-hmm. As the journey started, remember the journey started with a phone call to the helpline. That still exists. We do have low-tech approaches that are still available to help people exactly where they are. Some of the patient navigation we showed you is in a virtual environment. The model that we may pilot in Georgia could be more of an in-person environment. That relationship piece won't go away. So think of the technology as a platform to allow us to do more and do better, but it doesn't take away from how a person may choose to have that relationship with Komen.
Great. We have a question about reimbursement. Will we be looking to help with reimbursement for patient navigation services, whether it be through insurance, Medicaid, the BSEP program, that sort of thing?
Oh, that's one of my favorite questions in the whole world. Gosh, yes, in a perfect world. New York, can you hear me? Yes, this is what we would love to see. Right now, patient navigation is not a reimbursable service, and it's something that we need strong advocacy in order to achieve. One of the ways that has been explored, both by our New York affiliate and others, is showing the financial benefit of navigation. Unfortunately, we live in a world where, patient impact is important, but financial savings is just as important. We're having healthcare conversations, and that's a whole other webinar for us to have. But if we can show and contribute to the body of evidence that the provision of patient navigation not only improves outcomes, but also reduces healthcare expenses, this is a great argument for us to have. It will help, relieve an overburdened healthcare system to get patients to the care that they need, not what they don't need, and also helps to reduce the expenses that come when we lose someone to care only to have them have a catastrophic incident that requires more expensive and lengthy care. There's a lot of ways that we can come at this as an advocacy organization to affect that policy change, both with our elected officials, but also with our insurance providers. Some of our colleagues in California were doing just that, working directly with the insurance carrier to help people take advantage of benefits that would help reduce their healthcare expenses in the long haul. And we can do more of that.
We have a question about the selection of providers. How will that happen, particularly as it relates to both the patient navigator and then ultimately their healthcare provider, their doctor? Is this going to be done through referral? Will the patient select themselves?
Really complex question. So as many of you know, or any woman on this phone knows, one size does not fit all. And it's reflective of the complexity of the American healthcare system. It's dependent on your insurance status. It's depending on your location. It's dependent on whether Medicaid has been expanded. So not an easy question to answer. That will be one answer for the whole country. Navigation is really designed about helping an individual patient on their individual journey. And we as an organization, as I showed a few slides ago, that's something that we need to define as an organization as to where in the continuum do we want to set. Financial navigation is an art along the navigation continuum. But we need to help each individual patient, and a lot of that starts with an insurance conversation, unfortunately.
There's a question about the patient navigators. We talked about translation of materials earlier. Will these patient navigators be assigned by language? Will they be multilingual? How will that work?
Yes, all of the above. TBD. This is very much, again, it's very much an individual approach and something that together we need to build out. We do envision starting these with pilots. For example, those of you in the affiliates who have done this have served your communities. We're looking at a similar pilot in a rural area of Atlanta. These are the learnings that are going to help us build a robust response that can be scaled nationwide.
You mentioned that the Komen Health Cloud is not operational yet. What is the timeline for that, and are we planning any PR around that?
Dana?
Reverse order, yes. If and when it is launched, there will be quite a bit of media and branding around it. From timeline, as soon as Victoria enables us to go.
Thanks, friend. What Dana means to say is, so, with this evolution, right, this is a huge project. And those of you who work, who are working in public health understand, the magnitude of what we're about to undertake. So we have plans to bring part of these processes online first. So think about things that are more easily accessible. Like let's, for example, say our treatment assistance program. It's a process that we qualify patients and award grants. That's probably an easier way to start building the foundational framework than going straight to patient navigation. So we are on a fast track for this revolution, but we understand it does have to be iterative. We can't do everything at once, but we want to put the stake in the ground quickly to build this individual relationship with the patient. This dovetails into our patient registry big data program, because we need to be able to accrue people, invite people to come and give us their medical records so they can contribute to answering that question about recurrence. So we need to have a patient platform for people to start doing these things and interacting with us in a different way. So there'll be a beginning where we'll build that relationship, but everything that you've seen in this health cloud, right? No pun intended, but the sky's the limit with what we can do.
The question about the person-to-person handoff on this. How will the Komen patient navigators integrate with local healthcare providers and breast care coordinators? Would there be a handoff necessary?
Great question. It's like everything in community, it depends. So we need to envision together what the role of the patient navigator is. Early thinking and talking with many of you who are engaged in this space is Komen plays a unique role as a community resource, like being that person who looks like the patient who's going through treatment. And they have a collaborative relationship with a resource, whether it's a navigator or a nurse or other, at the healthcare setting. That may be a really good and impactful place for us to be in our navigation journey. But these are things that we need to work out together. And of course, it depends, because as you know, with every pilot and program that we do, there might be slight differences with how we can best impactfully serve, all to be grown.
Another question as it relates to the patient navigators, as with everything, we need to make sure that we're speaking the same language and definitions. Trying to understand patient navigators, is this a formal program or more of a peer-to-peer support program?
No, it is a formal program. So there are wildly different definitions of patient navigation. There's not one unified agreement on what a patient navigator does. Do they need to be certified? So there are varying beliefs about what a navigator does. That's something for Komen to decide together, is what does navigation what do we believe navigation to be for us, and what will we provide in collaboration with other healthcare providers. So I don't see this as peer support. That does not mean that the health cloud should or should not include peer support. I think that's a powerful part of how we build community. We think about people getting together, who recognize themselves in each other. Our African American community has gotten together through our In My Own Voice here at HQ, and through programs that y'all have been doing in your communities. Think about the community that we've created with our metastatic breast cancer patients through our Impact series and other events. Yep.
Switching gears to treatment assistance, will there be any changes to the qualification guidelines and amount of treatment assistance we provide?
Probably. The needs are going to grow over time. So like everything, it is all going to be driven by the financial means available to us. The payments are on the low side now because we want to help as many patients as possible. As our fundraising grows and as need grows, we can, as we push up the amount of money available, we can increase the amount of support that we can award and increase the number of patients. I've got to throw out a little piece of data. So our in-house data science team took a look at the number of people who are going to be diagnosed with breast cancer in a given year. And about a third of them experience poverty on some level, a third. If we were to award every single one of those patients who are experiencing financial distress, even a $300 award, the amount of money that we would need to award exceeds $100 million. There is no end to the amount of support that is needed.
Question, there was an example of someone being able, particularly the unbanked, being able to access their treatment assistance award through a Walmart cash center. Will there be fees associated with that? And if so, who pays those fees?
I hope not. Right. So, you know, we've talked a lot about how not every person who needs service from us has a bank account. And so we need to think about other ways that we can help people get the financial support they need in a really timely fashion. You know, there was an example in our partnership with Walmart. Could we do something with them that would allow our patients to access financial support without a fee and without a bank account? And that's just one example of how we have to think creatively about barriers.
There's a question about the fact that there's many, many touch points for the vision that you outlaid. Do we currently have the manpower to fulfill these roles, or do we have a plan for how that is going to be operationalized?
Yeah, we're not going to go from zero to everyone served overnight. We do have the foundation in place to provide the key services that I showed a few slides ago. So if you look at the 6 things that we talked about with our helpline, our treatment assistance program, clinical trials connection, NBC Impact Series, the work we're doing in the African American Health Equity Initiative, all those can be sustained right now. Those are the ones that will continue on immediately. We have opportunities to scale and grow every single one of those programs with the support of our colleagues out in the field. Every one of those is only scratching the incredible need that we know exists, so we can start there. The technology platform gives us the opportunity to build an individual relationship and to scale and grow. So we may use this technology platform to start. For example, maybe we start in our Atlanta pilot, and this is the way that we can begin to have a more robust response, and based on the learnings there, then go on to scale to 10, 20, 30 more areas.
There's been a couple questions that are Walmart related. Obviously, that piqued some interest. Is this an exclusive relationship for their service? And 2, what is our current relationship with Walmart? What does that currently cover?
Okay, so do I want to take that, or Dana or Paula?
Take it. So essentially, Walmart, we believe that we have a very strong relationship going into Walmart. We started this relationship last November. Where we started having conversations about what were the biggest problems in breast cancer and what could Walmart, if they threw their heft behind, what could they solve for us that no other organization could solve? So we had several meetings with them. We had disruptor days. We went there. We had conversations. We spent a lot of time with the Walmart folks and came out of it that the patient-centered services are really the most important thing that we're going to do. And they are the ones that are going to fund the app for us, and also the pilot program that we're putting on in Georgia. Their goal is to roll out, they have, I think, 4 clinics now. Their plan is to roll out over 100 throughout the next year. And then, sky's the limit on that one too, because they see this as a huge need and an opportunity. And what they want, right now, the plan is for us to be their partner in this and that we would be able to work together. They would bring mammograms, and all of this hasn't been worked out yet. The first start of it has started to work out, and then we would help with the continuum of care and the patient navigation. So there's opportunity in many communities coming up. We don't have their exact rollout plan, and we are working through all of this as we speak, but the first commitment has been made. And short of, the world falling apart and again, worse in the next 30 days, we don't anticipate any issue with that first commitment, which is the pilot program in Georgia and the money for the app.
I have a couple of questions that are related back to the helpline. One is are the patient navigators that are referred by the helpline specialists going to be Komen staff, the patient navigators? And if so, are they going to be in local markets or national staff at headquarters?
Mm-hmm. So I'd say I'll start with the pilot that we're envisioning, that it would be local staff in the local market. As we scale, we should be considering other models to ensure good coverage of service. As you all know, for some of you who work in really, really large states with vast service areas, having someone down the street is going to be really difficult. This is where the virtualization can support. Again, it's difficult to do one size fits all, but the starting pilot, as many of you have done in your communities, has been local staff locally embedded.
You mentioned a little bit about continuing education in communities. Can you explain a little more about what you're thinking of continuing the education in the community will be so that screening rates do not decrease?
Oh, wow. Great question. Gosh, not only do we need education, we're going to need a heck of a lot of advocacy to keep the BSEP programs funded, everybody. We're going to have a little bit of time in our hands focused on this issue. We have a lot of fear and uncertainty in our communities right now about even going in for a routine mammogram because of fears about catching the virus. So I think we already have communities that were distrustful of the medical community already. We have a lot of other issues layered on top of it, plus a diminishing of safety net services and many more people who are going uninsured. So a few months ago, we thought we had been doing really well with improving screening rates, but we may be seeing that we are going to have to get back to some basics. I think that's how I'll answer that for now. But the biggest concern that I have at the moment is the vast number of people who are unemployed, uninsured, and the safety net services that we've become to rely on going away.
Another question about how this new system will integrate in with existing platforms. How will our Komen patient navigators work with local hospitals who have their own navigators?
I think it's going to be a partnership and a collaboration. Whether or not we will be able to link into their systems, if they're using Epic or other systems, I think that's something Dana and I can explore to make the relationship more seamless. It is exceptionally difficult for patients to have one record of their breast cancer treatment journey, and we'd like to overcome that barrier, but it will require a lot of discussion. Many of you know that we have not quite solved the problem that is electronic health records, and we will have to work long and hard to get that done.
Going back to the example of the mobile mammography van that was at Walmart, will this be exclusive to Walmart, or will we see things like mobile mammography going to other areas to ensure that we are getting the most high-risk populations, including African Americans, low-income, elderly, that sort of thing?
It depends. I think this is one of the many things that the Mission Advisory Committee needs to tackle as we take a look at the emerging landscape on the other side of COVID-19 to see which one of these or which of these many programs we can prioritize. With our limited resources, we won't be able to do everything. So it's difficult for me to say yes, we will do this, and no, we will not do that. These are things that we need to discuss collectively. We will have limited dollars and limited resources. Could mobile mammography be one of those answers in a community? Yes. But there are a lot of answers to the problem of serving breast cancer patients. We're going to have to be very, very thoughtful.
Obviously, a lot of this conversation has been on the patient experience and the health cloud, but we do have a couple of questions about some of the other things. Can you tell us a little bit about what is going to be the focus of our research program moving forward? Is it going to be exclusive to this big data project?
Oh, I hope not. So think of the big data project. So I saw someone else in another chat. Sorry, Sean, I'm cheating again. Was asking what exactly is big data? Great question. That's another one of those things that we all seem to know what it is, but there's varying definitions of what it is. So big data is uniting many different data sources to answer a question. People sometimes think it just means a lot more of the same data, but it isn't. So think about uniting medical records with imaging data, with your device that you wear on your wrist, with the outcomes and the side effects. And I'm probably leaving a bunch of other things out, Dana, genomic testing, genetic testing, pulling all this data together to paint an incredibly comprehensive picture of breast cancer. Our goal is to build this platform that not only helps patients be part of the research process, but gives an incredibly powerful tool to researchers that does not exist anywhere else. No one else has this. No one else is doing this in breast cancer. Other disease sites are attempting this. We would be the first, and it would be the most valuable resource to research that we have. There's lots of data like this that exists in different cancer centers, but it's very siloed. It doesn't work together, and it's very difficult for researchers outside of the academic bubble to access this. In the field, we talk a lot about data sharing and team science, and it makes for really nice white papers and platform presentations at SABCS. But in practice, this isn't really what happens. And part of what Komen can do, this is our big ability, we can break down those academic silos and be the trusted broker, not only for patients to trust us, but for researchers to work with us and then share their data back. So think of this really as the platform to drive a lot of future discovery, and we hope it will accelerate progress. This is not the only thing that we will do. Much as I've been talking about with our colleagues in the field, that grant making is not the only way that we impact community. We also do a lot of other things in research. And the team is actually working on a conversation for down the road to share with you some of those other things that we're doing to advance the field in clinical trials, correlative studies. There's a lot that we're doing. So stay tuned. Our focus will continue to be primarily on recurrence and metastasis because it aligns with our bold goal. Someone said the word Shiro. I don't know if I'm allowed to say what it is, Dana.
Sure.
Okay, all right, just checking. I don't want to. So Shiro is what we've conceived to be the very first study. Shiro, SHERO. It is the study helping estrogen receptor positive outcomes. Many of you know that women who are diagnosed with early stage ER-positive breast cancer are those who, again, done everything right, screening guidelines, care path, only to have a late recurrence. Why, when everything was done right, are these women being diagnosed then with a recurrence of metastatic disease that's now incurable? We need to answer this question. We need to answer that question and many research questions that continue to vex the field. But this is the first study. It's an important study. It is a critical study to our community. And I think it's one that we can make great progress on together. So we've been talking about this so much. I'm just going to have to put a press release out to talk about it. I'm super excited. But so think about the big data as the platform to accelerate discovery. But what the platform gives us is an almost, Stephanie Reefe will kill me, an almost infinite ability to ask a lot of questions. We don't have to stop there.
Question about some of the current things that we do currently and whether or not they're going to continue. The first one is about the metastatic breast cancer conferences. Should we still continue to do those in the fall and moving forward?
So I know that many of our affiliate colleagues are looking to virtualize those since we don't know if public health guidelines are going to allow us to convene. And I'd also encourage everybody to virtualize as much as you can for the coming calendar year. especially if you're serving the metastatic community that is at higher risk of complications from infection. So please, I know we all want to get out of our houses and hug each other and be together as a community, but please think about virtualizing to help protect the patients that we serve. I do think we need to find ways to come back together, again, as resources and public health guidelines allow, on the metastatic topics and on other topics, advocacy and other things that need us to get together. So yes, that should come back in the future.
There was another question about a project that I know our affiliate colleagues always look forward to undertaking. Will, under this new model, we still have a need to do our community profiles?
Oh, great question. So as you know, we put a slowdown on starting the profile process for this year, just in deference to the enormous challenges that our colleagues in the field are having. I don't think you need one more deadline as we're navigating through this tough times. I think we will always need to illustrate and assess where the greatest needs are in service to our communities, so that we are very mindful about where we are applying our resources, right? That part will never go away. But you all know this is also an important tool for us when we're communicating to our donors and our supporters the reason why. Why do we still need to do this? So yes, we probably need to revision how we do the profiles and provide the data that allows us to target our resources and also tell our stories.
Another question as it relates to things that we currently do and whether or not they will continue under this new vision. From the fundraising side, will we continue to have our races and our walks?
Yes, the whole plan is, I do believe that at some point in the future, people will go to a baseball game, they'll go to a concert, and they'll go to a race and walk. But we have to be careful when we decide to do that, because we certainly don't want to bring a compromised community all together where we could put them at risk. So we don't know when that's going to be. No one does, and it really does. It comes down to the basic science of what's going to happen with COVID. So we have to be prepared to be able to put on races and walks, and certainly we can pivot those to online or virtual experiences, but we all know that it doesn't bring our community together, and it's not going to raise near as much money. So we hope very much that we will continue to build on the franchise that we've worked 35 years to build.
Getting back to mission and the relationship of our patient navigators in this program with the local health systems, and whether that they have navigators themselves, specifically on the technology, is there an opportunity for the Komen Health Cloud to be used by hospital navigators in their system so that we can bring them into the Komen family as well?
We think so. Okay, respect to the other technology companies out there. We have not solved the issue of electronic health records or a seamless care journey. I think, Dana, our vision is that this could be transformational across a variety of platforms. I'll let you talk about that.
Yeah, I mean, I think access to the platform is role permission based. It can even be a monetization strategy. I mean, that, there's no technical barrier there. In terms of, ingesting records from other systems, again, many times it just defaults down to, the willingness to partner, right, between teams and organizations. Again, it's not always just a technology challenge. So, not just through Walmart, but through other partners as well. We've been introduced to some of the top players in medical technology. I'll tell you, for example, we've had multiple conversations with the chief medical officer for IBM Watson Health. You can form your own opinion directly about their solutions, but they are on the front line with at least being posed the challenge to solve the toughest problems. When they saw these wireframes, and again, we just want to reiterate, these are wireframes. This is not an operational software system yet. But he's basically, literally his words were, "This is brilliant. No one has this," right? Most of the solutions available today are focused on the providers and the payers. Nobody's focusing on the patient. And so putting the patient at the center of our work is going to be transformational. And I do think that the payers and providers will be greatly incentivized to work together because they want to be where the patients are as well.
Mhm.
So yeah, I think that there's a lot of promise there. I also think that the disruption that Walmart is bringing from a business model, to some extent, regardless of where our partnership with them goes, but they are going to totally disrupt the relationship again between the patient, the care provider, and the payers.
Mhm.
And we can be in a prime position to be as a part. Victoria used the word, democratization, right? It's real, right? And it's coming. And so the more that we can work together with those that are on the front lines of thinking through that disruption, we're going to be in a better position, and we're going to be in a competitively differentiated position as well.
And just, and always remembering that we primarily serve the patient, protecting the patient's, rights and access. It's one way we have to ensure that we always have the trust of the patient, right? We're there, as Dana says, we are representing the patient. That makes us incredibly unique and valuable.
There was a question about insurance coverage with these people who get access through the Walmart clinics and into the Komen Health Cloud. Are these primarily going to be people that are covered by the safety net programs or insurance, or how will that insurance work?
We don't know yet. So I think one thing to be clear is that the Health Cloud is not just a vision for Walmart. It's one partnership that could be supported through this platform. The vision is that the cloud, starting with the helpline and the treatment assistance program, is just supporting the backbone of what it's what we already do. So the evolution into this isn't contingent upon a PatNav pilot in Georgia. This is something that we're going to do to support our services that exist right now better. So I want to start there. So in terms of if we did the pilot in Atlanta, or if we did a pilot anywhere else, these are all considerations that have to be made when you're designing the program. What happens when an insured comes through the door, and what kind of insurance do they have? And that sometimes limits the providers that you can access. You all are dealing with this in your communities right now, that if you have Kaiser versus Blue Cross versus Anthem, that answer can be very different. There is no one size fits all here. So regardless of the partner, the insured status is important. What we do for people who are under or uninsured is important. But the underlying guiding tenet of Komen remains the same, is that you can't get a person into screening and then lose them to care. Every partnership has to be designed to carry them through, regardless of who we're partnering with.
There's a question about you mentioned a few affiliates have patient navigation programs. Is there a list or can you give some more examples of affiliates that have lay patient navigator programs in place?
Sure. Yeah, we can share those back out with the affiliates so you can see what some of your colleagues are doing.
There's a question about once again, back to Walmart. Obviously, this is exciting and intriguing news. Is the app that we're developing for the Komen Cloud, is that going to be owned by Komen, or is that going to be owned by Walmart?
No, owned by Komen.
On the Shiro study, is this just for clarity purposes, is this an entirely Komen-funded research study?
It is funded in partnership with a number of organizations. Shiro is a massive study, and it's a massive and expensive and complex study. Research is not an inexpensive pursuit, and especially for a project like Shiro that is designed to gather massive amounts of data like never before, it is expensive. So it is the primary focus of our partnership development in the field. We have funding from generous donors that are allowing us to get started and to accrue the first group of patients, but we will need more to complete accrual for the study. It's a long-time process, but it's going to be very worth it.
Getting back to a few questions about Walmart. One is, how does the Walmart funding, how long does it last? And what are plans for continued funding for these types of activities if the Walmart funding dries up?
Well, this is still a proposal. It's not a done deal. So it's not done yet. We hope that with this partner or any partner, when we enter into a project, that we demonstrate our value and our impact. Two important things. Some of the programs that we've piloted in the past have not achieved their goals, right? So, that's where a conversation with a donor happens to say, is this something that we need to adjust and move on, or an idea that was great but doesn't work, so let's do something different. So I think with any partnership, there's usually a pilot phase for us to determine whether we are creating that value and impact. This is where evaluation and measurement is really, really important, is gathering the data to show that what Komen brings to the table is actually moving the needle, the impact and saving lives for patients. But if this is also important to demonstrate the economic savings and the economics that we bring to the table. So it depends. It always depends with the programs.
And then finally, there was a question, you mentioned that Walmart is planning to be a disruptor in the space. Just for clarity, is Walmart moving into the healthcare space?
They already have. Paula, do you want to address that, since you spent a lot of time with their health folks?
They have, they are definitely in the space. And they hired a gentleman by the name of Sean Slavinsky, who's their SVP of Walmart Health, and he is a complete disruptor. They've started with 4 clinics that are all in Georgia. There's 3, and then 1 is opening in June. And essentially they're state-of-the-art clinics, really fantastic, but you can go in there and you can have a pediatric visit for $20, an adult visit for $30, less than you would pay if you were going to use your copay. You can get your teeth cleaned for $29. They want to have mammograms for $49. Unless if someone is insured, then of course they'll take the insurance. But many people come in and are not insured, so they have the ability to have their families seen by a local doctor, and they can actually also make payments. They can make payments of $5 a month, which is pretty incredible. They started this with the goal of moving this out and rolling it out in a pretty substantial way. And then COVID came in, which really just enforced their thought process about moving twice as fast as they were going to before, because they can see that this will be something that is very, very important to them. And it's going to disrupt healthcare because of the price points, that you can get your teeth cleaned and an x-ray for $29 is pretty incredible, or an eye exam for $20 is pretty incredible. So, they are disrupting. They want us to disrupt with them. They are really excited about the partnership. And we have invoiced them for the first pilot program and for the app. I don't foresee any issues with them paying the money, because they're actually doing very well. But that's where we are in the process. And then when asked, by their legal department, which was the next state that they wanted to work on, Sean Slavinsky said the United States. So they want to roll this out, and they want us to be a partner with them in theory, right? We don't have it done yet, but in theory throughout the United States. It would be wonderful as that happens. But regardless, we are still moving in this direction of being more direct to patient. So that would just give us a huge boost.
There's a question about timing. Obviously, we've talked about the health cloud, and all of this is not operational yet. Any indication on when we might be able to start communicating about this new app to our communities?
Zaina? Yeah, tough to say. Tough.
Yeah, I want to think about it a bit. I think from a strategic standpoint, I often use the phrase, I want to, plan a couple chess moves ahead. So, I want to think about, right, how quickly we can go to market with talking about it. It is a great way to do first-person market research. You get a lot of feedback on what people want, what they think current problems, barriers are. But I don't have a defined time frame in mind yet. So it would definitely be this calendar year. That's probably all the more clarity, right, we could give at this point. So.
Mm-hmm.
I've seen a few chats on the 75-25. So let's address that, because I don't want to not say it or not talk about it, because we just are not sure, right? Because we have to survive, And in order for us to survive, we may have to use some of that money for operational, like I talked about in the very beginning. There's a lot of local affiliates that have asked for us as HQ to not take the 25% for research, because if that would cause, undue pressure and perhaps a significant amount of affiliates to go out of business. So we're working through that. So we can't be all things to all people as we're trying to figure out which direction that we're going in and what do we need? What do we need to make sure that we're in business? What do we make sure that we have community presence? So we're working through all of that. I don't have all the answers. Of course, we would like to maintain donor intent, and specifically if there are restricted dollars, then we want to make sure that we spend those in the right way. And I know that the communities have raised a lot of their money, whether it's to be used up to 75% or it was a hard 75%. But we're in a moment in time here where we want to just make sure that we can come out of this alive and that we can be here, because if we're not here, no one else is. So this is fluid. We're going to continue talking about it. I don't have all the answers right now because we're still trying to figure out what does the revenue model look like. And, and the 75% that's used in community, you still have to pay people that are in those communities, right? We're still going to have staffs in all of these communities. We're figuring out what does that staff look like. The majority of it will be in fundraising, but there are some other gaps that we're looking at. And we've started this process of understanding all of the gaps that we think that there are within our organization and what people are out in the field that can help with those gaps. So you got to give us a minute to figure this out, because no one knows where we are right now or how much we're going to be affected in the next 2 months, 3 months, 4 months. So that may not be the answer that people want, but at least it's honest.
All righty. I think we have covered just about every question. Some of them were duplicates and we tried to merge some. So we'll go back over these and make sure that there was nothing left out and answer those directly. But at that time, I think this is a good time for some final thoughts from our panelists.
Yeah, this is Victoria. I just want to say that this is the first of many conversations that we need to have in the field. But I also encourage my colleagues to also have conversations with your field. I know we talk a lot about donor intent. I want to go back to the sense of community. The money raised here stays here. And I respect that, and I want to honor donor intent, but I also want us to lean in to have a conversation. And this is an opportunity for us to share with those who support our mission and support our organization, and to share with them where we are. We've all signed up to be part of this organization because we care deeply about the mission and being able to serve. And that's an honest and fair conversation for us to be having. So have the conversation and share with people what we need to be doing to continue to serve and survive. As I said at the beginning, we hold a unique and precious role in the community as someone who's been around cancer for a very long time. It's hard to overestimate the impact that we have had on people, on progress, on science, on policy. And that impact is going to be needed more than ever. I want to be part of this difference, and I want us to come out on the other side. I want us to serve in ways we've never served. I want us to achieve this bold goal. So that is my impassioned plea. I said I wasn't going to get passionate. It's not very cheerleadery, but that's my impassioned plea to all of you who care so deeply about this work. So thanks everyone for listening. I look forward to having more conversations with you about my favorite topic, mission. So.
Yeah, and I want to close by thanking everyone for listening today. We had the largest audience that we've ever had, which I anticipated because there's so much change and this is so fluid right now. And I know we sort of threw a lot at you, and these are just the art of possible, right? We know that the Walmart thing isn't built yet. We understand that. We understand that you're concerned about what's going to happen in your community. We understand that. We're trying to figure out what the best way forward is in a very cash constricted environment. What we don't want to do is just watch as affiliates go out of business one by one because we can't have races or walks. We're trying to figure out all of the best parts and pieces to go through this. But if you remember sort of three things from what we talked about today, is one is we didn't feel that we had any choice but to restructure because of COVID and because of the economic realities that we are. This requires it. And two, that we are not leaving communities, regardless of how you personally define communities. We want you to know that there are ways for us to stay connected to Komen. And we've discussed a lot of those opportunities, and we will continue to have an open dialogue with the affiliates to make sure that we are discussing those opportunities, because what community looks like to one person may be completely different, because you all have your own community input. And if we focus on the things that are the third thing is if we focus on the things that have the greatest potential to help patients today and get us closer to discovering the cures for breast cancer, then we can stay relevant and critical as we've ever been. And we have to do these things. You know, here's the impassioned cry on my part, as I'm a breast cancer survivor. I didn't come here for the glory of the role. I came here because I wanted to make a difference. And my mom had it. My sister has a biopsy tomorrow. I had it. I have 2 daughters. Enough said. You didn't come here because this is just a job. You came here, or you're on the boards here because you care about the cause. So our survival is on the line. We have to figure out ways that we can stay in the role that is so incredibly important. And if not us, and if not you, then who will be there for breast cancer patients? Because there is no one to take our place. So I thank you. I hope that you will support the efforts. I hope you will remain on boards. I hope that you can work with us on this transformation, because it's not going to be easy. It's going to be bumpy. But we can get through it, and we are stronger together. So I really, truly appreciate all of you and all of the work and all of the considerations that are in front of us. Help us get through it. This is an important organization. We deserve to thrive, and we certainly deserve to survive first and then to thrive. So thank you for your time today. I know it was a lot of time, but I hope you found it interesting. There's a lot of work that is being done, and we're going to continue. So we will make it through. We may look a little bit different on the other side, but stay with us. Okay? Thank you. Appreciate it.